So I would like to welcome everyone to this webinar. So this is the ELF PH PAG group, and my name is Hals Gård, and I'm from Norway, and I'm actually a PH patient. I was diagnosed 19 years ago. And this PAG group, Patient Advisory Group, was established last year, so it's fairly new. And the group consists of people from different PH associations. And this is the first event that we run. I should mention, if you can go to the next slide, please, that there will be translated captions available for those of you that don't speak English. So this is a Q&A session, question and answer sessions. So I hope you all have had a chance to look at the presentations first. That's available on the ELF page. So it's 6 different presentations. 2 are given by patients. One patient is talking about going from childhood to adulthood with PH, and the other patient is talking about being part of trials. And then we have 4 presentations given by PH experts. And we talk about symptoms of PH, causes and classifications of PH, and then treatment for each cause. And then at the end, new treatment for PH, clinical trials and drugs in development. And these are 4 excellent presentations, and if you have not had a chance to look at them yet, then I think still the session would be valuable for you, but definitely afterwards you should go and have a look at them. So here are some housekeeping rules. As you can see there, read there. So I think I should just start by welcoming our panelists, the PH experts. So I'm going to make it easy on myself and just simply ask you to introduce yourself. So maybe we can start with you, Dr. Picari.
Yes, good morning. Thank you for inviting me to this event. I'm very excited to be here. My name is Lucilla Picari. I'm a pulmonologist specialized in pulmonary hypertension who works in Hospital del Mar, Barcelona. And I am the coordinator of the Spanish Registry for Pulmonary Hypertension associated with respiratory disease. And I'm also the director of the Spanish Pulmonology Society for Research on Pulmonary Circulation.
Excellent. Thank you for being here. And then next is Dr. Buchli. Is that how you pronounce your name?
Good morning, everyone. I'm Athénaïs Buchli, so the pronunciation is perfect. Thanks. So I'm a French pulmonologist, and I work in the French Reference Center of Pulmonary Hypertension.
Thank you. And then I think Professor Jean-Luc Vachiré maybe is not here yet, but hopefully he will join us a little later. And then we have Dr. Jason Weatherald from Canada, but at the moment in Denmark, I understand.
Hi, yes, thanks for the introduction. I'm Jason Weatherald. I'm also a pulmonologist in Edmonton in Canada at the University of Alberta. I work in pulmonary hypertension and lung transplantation, and I fortunately happen to be in Denmark right now. So the timing of this is perfect.
Excellent. Okay, so I think we'll just get started. So we have 1 hour, so it will be about 15 minutes with question and answers to each of the presentations. And if there are any questions that we don't manage to go through because of time, then we will get answers to them and post it on our website. I see we have Professor Vachiré here. Maybe you can give a short introduction to yourself.
Sure. Good morning, everyone. So my name is Jean-Luc Vachieri. I'm a cardiologist, and I'm the head of the Pulmonary Hypertension and Heart Failure Clinic at the HUB, Hôpital Universitaire de Bruxelles in Brussels, Belgium.
Excellent. Thank you for being here. Okay, so let's start with the first presentations, talking about symptoms of PH. So the first question is, the pulmonary pressure is an indication. Is the pulmonary pressure an indication of severity of PH? And can it be compared from person to person?
Yes, this is a very relevant question. The pulmonary pressure is enters the definition of pH, of course, but it is only one of the parameters that we measure when we study pulmonary hypertension. And in fact, pulmonary pressure is not featured in any of the many tools that we have to assess the risk of a certain patient in the coming years. So it is not strictly considered a parameter of severity. In this respect, the function of the right ventricle is much more relevant. It's something that we really focus on when we want to assess the severity of the patient, but there's many other things that we actually check, like other symptoms, the distance that patients are able to walk in the 6-minute walk test. So to compare pulmonary pressures is not really a good indication because it's only one parameter and it's not even the most important one. It can give something of an idea, but it's really not, I wouldn't recommend comparing it from patient to patient because it's not very relevant.
Right. Next question, could you elaborate on what preserved functional capacity means? And when you talked about this in your presentation, you were referring to maybe young people. And does this mean that it takes maybe a longer time to get them diagnosed, that they're diagnosed at a later stage?
Yes, this is also an excellent question. Young lungs have a bigger ability to withstand an exercise. So if you go from 1 to 100 when you're young, you're going to be able to tolerate it much better than when you're older. This is a physiologic condition, so it's normal in any case. So this means that when a disease comes around in the lungs, it may take a bigger effort for a young person to feel that there is actually something that is not right. It may take them to do a more strenuous effort to feel that something is not working properly. And indeed, this may mean that patients, young patients who develop pulmonary hypertension might not realize as quickly as an older patient that the lungs have trouble breathing and that something is not right. So it is possible that there is a delay in diagnosis if someone develops pulmonary hypertension at a younger age. Yes.
Okay. Then we have a question about fatigue and tiredness. Like a healthy person will also experience tiredness, but what is the difference between fatigue and tiredness, and how can you distinguish the two?
Yes, I understand that this is it's a capital question because we always say fatigue is one of the main symptoms, and yet fatigue is such a vague concept, right? We can all feel like we are fatigued at the end of the day, but I think for one thing, there is a difference between fatigue is very subjective, and there is a difference between physical and fatigue brought about by stress or mental fatigue. So maybe we will feel tired because we've had a long day of work, but it doesn't mean that physically we feel fatigued. So pulmonary hypertension typically manifests itself with the feeling, a physical feeling of being exhausted in a physical way. Having said so, it is true that it's very subjective. So some people may experience this in different ways. In any case, the important thing is a comparison with the past. So if in the past, a person was able to do a certain amount of physical exercise and not feel that feeling of fatigue at the end, and they do the exact same thing in the same conditions and they do feel fatigue, then it's probably a good idea to consult the doctor about it, to tell them, hey, doctor, I was able to do this walk out of my house with no problems. And now I see that I get breathless or I am just exhausted at the end of the walk.
I talked to one of my PH friends, and he talked about fatigue, and then he compared it to a fish in water just standing still with the mouth open. He said if he's fatigued, he cannot do anything. He cannot really think clear. You know, everything is just difficult for him.
Yeah, absolutely. Some PH patients describe it as a sense of oppression or of being completely drained. So it may take different feelings, and this is normal because, as we said, it's a very vague symptom. But it's important to, I think, to listen to oneself and to really. But the important thing is to compare similar degrees of exertion. This is crucial.
Then we have a question about palpitations. There are common symptoms for PH patients. So what is the difference between palpitation and atrial fibrillation? Are palpitations usually just innocent extra beats? Or when should one be concerned about palpitations?
Yes, it is a very common symptoms, palpitations, and extra beats, innocent extra beats are very common. They are extremely prevalent in the general population and they don't mean anything. They're innocent because there is no associated disease with it. So palpitations are the feeling of having your heart beat very fast in your throat, maybe, or in your chest, like feeling the physical heartbeat on your chest. And they are very common. Atrial fibrillation, on the other hand, is not a symptom, it's a diagnosis. And it means that the heart is beating irregularly and it's a precise diagnosis. So it needs to be diagnosed by a doctor with tests. Palpitations are also very common in pulmonary hypertension because they can be brought about by exercise, and they might mean that a patient with pulmonary hypertension may develop atrial fibrillation, or they might also have an innocent extra beat, or they might have just the heart racing very quickly due to the exercise. In any case, again, as I mentioned with fatigue, if you notice palpitation that you didn't notice before, it is relevant to mention this to your doctor to see whether there is something else apart from the innocent extra beat to get it checked out.
Then we have a question about fluid retention. Is it possible to have swelling of the abdomen without swelling of the ankles? If so, why? How could one detect swelling of the abdomen as opposed to simply weight gain due to extra fat tissue? Because swelling of the ankles, they're easy to detect since one can apply pressure with the finger.
Yes, fair enough. That is a good question. So as to the first part of the question, is it possible? Yes, it's absolutely possible to have swelling of the abdomen without swelling of the ankles. Why is a bit complex. There are many reasons for this, but definitely swelling of the abdomen due to fluid retention is, well, the first thing that will point to swelling for fluid retention as opposed to fat is that it comes around in a much shorter period of time. So we're talking days instead of weeks, basically. So if your abdomen swells over the course of a few days, then it really probably is not fat. And also, usually it happens in the absence of differences in diet or exercise. So the input of energy and the output of energy is the same, and yet the abdomen is swelling. It is true that it's harder to identify from the personal point of view. It's hard to realize that the abdomen is swelled from fluid, as opposed to the ankles where you can just put your finger. But your doctor is able to make that distinction by doing a careful examination, physical examination, and seeing there are some signs that will tell the doctor that this is fluid and it's not fat. So again, if you notice that your abdomen has swollen in the course of a few days, and perhaps when it's accompanied by other symptoms like shortness of breath and fatigue and palpitations, then definitely mention it to your doctor.
And then maybe also is a good thing for patients to weigh themselves regularly so they can see if there is a big change suddenly in weight.
That is a very good point. Yes, and again, it's a quickness of this coming about. Like if you gain 2 or 3 or 4 kilos in 3 days, then it's not going to be fat.
Yeah, but for instance, for myself, I noticed if I go on a plane ride, then I will weigh a little bit more for at least 1 day before the retention disappears.
Going back to normal. Yes, that's another thing. Like if it's quickly reversible, then, you know, it might be something intervening, like, you know, just being more sedentary for maybe 1 day. But if you notice that this is happening and it keeps on happening and it's not going away, then yeah, definitely consult your doctor.
Being in good physical shape is always beneficial. However, isn't it especially useful when diagnosed with PH? A person in good shape will more quickly realize that something is seriously wrong compared to someone who is not exercising. Is that correct to assume?
Being in good physical shape is definitely always beneficial. It's, you know, it's a good idea to be in good physical shape. And it is true that if someone does exercise regularly, they will be more able to tell when something is wrong if they're not able to breathe as before. At the same time, sometimes people who develop a lung condition progressively over time, they will lower their level of exercise progressively without even recognizing it. They kind of adjust to what they can do. And this is a very common and normal response. But this means that one has to sort of make the effort of going back in time and thinking, oh, was I able to walk that far a month ago or 3 months ago, and now I can't? Am I walking less because I don't want to walk more, or because I'm trying to adapt to my shortness of breath?
Why does shortness of breath occur when bending forwards, commonly in PH patients?
Yes, this is a very pertinent question. It happens because on one side, bending forward for a moment, the blood can't quite very well reach the right heart, which you know, is obviously aggravating a situation of a right heart that is already having trouble pumping, for instance, if the right heart function is not good. And also at the same time, the movements of the thoraco-pulmonary abdominal system, so basically the rib cage, the lungs, and the diaphragm, cannot move quite as efficiently as one is standing upright. So the shortness of breath is caused by this very uncomfortable position for the heart and the lungs to breathe. And so it kind of exacerbates in the moment shortness of breath that is already there anyway.
Well, thank you so much. That was all the questions for your presentation.
Thank you, my pleasure.
We'll move on to the next one, which was the causes and classification of PH. So the first question is, symptoms are not very specific to PH. So what can we do, in your opinion, to diagnose pulmonary hypertension at an earlier stage than today? Okay,
so to be honest, I'm not sure we can diagnose PH at a very early stage, because as I explained in the video, the diagnosis of PH is not easy because the symptoms are not specific to the disease. But what we can do is raise awareness of the disease, which is sometimes misunderstood among general practitioners, but also among specialists such as pulmonologists or cardiologists, just to consider the diagnosis in case of these non-specific symptoms.
Yeah, and I think this is also a case where patient associations can do a lot, to raise awareness for PH. Right heart catheterization is the gold standard for diagnosing PH. Can a diagnosis be made without right heart catheterization? And must right heart catheterization be performed before prescribing PH medication? And can you foresee a development of a non-invasive diagnosis tool in the near future?
So today, Right-at-Cat is required to diagnose PH, and it's also required before initiating PAH therapy. So this is very important to understand. Of course, it will be great to have such a non-invasive tool which will be able to diagnose PH as a Right-at-Cat can do. But today, we don't have these tools. And I would like to remind you that echocardiography is not able to make the diagnosis of PH because it's not accurate enough to diagnose PH.
Right. So right heart cath, it's uncomfortable for a PH patient. And is it necessary to undergo this procedure repeatedly during checkup after diagnosis? And are there any risks associated with performing right heart cath?
So this is an important question, of course, and we totally agree with you that Right-at-Cat is not the most present procedure in PH patients. That's why we have sought to determine when this procedure is necessary and when we can avoid it. So you probably know that the minimal set needed to assess the severity of PH comprises 3 variables, which are functional class, which assesses the shortness of breath, exercise limitation. The second one is the 6-minute walk test. And the third one is BNP or NT-proBNP, which are measured in blood samples. So according to these 3 variables, we can identify the less severe patients. And in those patients, Right-at-Cat is not required. Treatment will be continued as before. And we can also, using these 3 variables, identify the most severe patients. And again, in those patients, Right-at-Cat is not necessary either. But in between, in the patients who are not at low risk, neither at high risk, we consider that Right-at-Cat is a very important tool to assess the severity of the disease and to choose the right treatment for the right patient. So this is the first part of my question, of my answer. And the second question was about the complication of Right-at-Cat. So of course, the most important complications, the most frequent complications are vagal reaction, arrhythmia, and hematoma. But that's why Right-at-Cat, it's recommended to perform this Right-at-Cat in experienced center, because the more you practice, the less the complication.
Right. Then a question about gene mutation. What triggers a gene mutation? What are the chances of developing PH if you have a gene mutation? And does it depend on lifestyle factors? For instance, can extreme endurance sports, high altitude exposure, or viral infections trigger PH when one suffers from a gene mutation?
Okay, that's an interesting question. Endurance sports and high altitude exposure or viral infections are not non-triggers of pulmonary hypertension, but certain drugs such as anorexigen drugs, which are no longer available, may be triggers in predisposed patients with a gene mutation.
Yeah, because I guess even if you have a mutation, it's not given that you have you get PH. So
it's not very clear, and we cannot explain why some patients will develop PH and some others will not. So we don't have enough knowledge today to answer this question. So we know that some drugs can induce PH and can be considered as triggered in these patients with a predisposed gene mutation, but we don't know yet. But I'm pretty sure that sports and viral infections are not triggers in PH.
How can we distinguish between a person with idiopathic PAH group 1 and a patient diagnosed with group 5. In both cases, the cause of PH is marked as unknown.
Okay, so I'm sorry if my presentation was not clear on this point, so I'm gonna try to clarify it. So both group 1, which is also called pulmonary arterial hypertension, and group 5 are precapillary pulmonary hypertension, but their mechanisms are totally different. If I start with a group 5, which is also called PH with unclear or multifactorial mechanisms, it's always there is always an underlying condition, an underlying disease, which explains the pulmonary hypertension, such as sarcoidosis, chronic renal failure, or chronic myeloproliferative neoplasm. So in the group 5, there is always an underlying condition, whereas in PAH, in idiopathic PAH, there is no underlying disease.
It's not true that many PH patients might belong to multiple groups of PH.
In theory, a patient can belong to more than one group, but it's extremely rare.
Okay. I've heard that the current PH classification scheme might become obsolete. Do you think there will be a new classification scheme or groups in the future?
PH classification evolves in line with advances in knowledge. So the current classification therefore corresponds to the current state of knowledge, but it cannot be ruled out that in the years to come that the classification will evolve with the new knowledge if science provides new information.
PH medications is often prescribed based on group classification. Will the anticipated shift towards personalized medicine change this approach?
Good question. For the moment, no. There is still no personalized medicine for PH. The treatment algorithm is based on the type of PH, so the PH group, but also its severity. But maybe it will evolve in the future.
Yeah. A person diagnosed with idiopathic PAH, is there any reason to undergo genetic testing? And will it affect the medication prescribed?
Okay, I can talk about what is happening in France, but I'm not familiar with the organization in the other countries. In France, we offer genetic testing to all patients diagnosed with idiopathic pulmonary arterial hypertension. This is because we can only conclude that the etiology is idiopathic once we have ruled out all other diagnoses, all other causes, in particular the genetic cause. And the treatment algorithm will be the same if the patient has idiopathic PAH or heritable PAH, but what differs is that genetic counseling will be offered to relatives of patients with heritable PAH.
Yeah, like in my case, I was diagnosed 19 years ago and I was unknown idiopathic PAH. And then, but I have never undergone genetic testing. So, you know, maybe that's something that the person should do after so many years. Is it advisable to screen at-risk population, so scleroderma, congenital heart disease patients, etc.? And how about the general population? Could that be those be screened as well?
So population at risk, such as scleroderma, but also portal hypertension prior to liver transplantation are already screened, at least in France. I don't know in other countries, but in France they are screened. But I think it's not reasonable to consider screening the general population because this is a very rare disease. And before considering this diagnosis and investigating it, I think we should first consider the most common diagnosis.
Right. Yeah, and the screening would probably also be difficult, like you talked about the right heart cath is like the gold standard, and so it would not make sense to.
Yeah, sorry. For screening, we use echocardiography, which is a good tool for screening, but not enough accurate to make a good diagnosis and to draw definite conclusion according to this tool.
Right. Okay. Okay. Thank you so much. That was all your questions. Thank you.
Very much.
And then we move on to the next presentation, treatments for each of the causes with Professor Vacheri. So first question, you mentioned endpoints in clinical trials. We've seen a shift in endpoints from 6-minute walk distance to time to clinical worsening. What do you think the future holds regarding endpoints, and will this affect the time it takes for drugs to reach the market? Because we know that time to clinical worsening is more time consuming in trials. And additionally, there seems to be a trend towards including more health-related quality of life endpoints through patient-reported outcomes.
Thank you, Hal. There's a lot of layers in that question, but I think that the bottom line is that we raised the bar quite high now. We know that the treatments we're using have the potential to improve some of the functional outcomes, such as 6-minute walking distance or hemodynamics. And what is now being a greater focus of interest would be maintenance of treatment or sustained effect over the long time. Now, you need to trade that off, as you said, between the will to get more information about long-term results for patients, such as decrease in hospitalization survival, for example, and also the time and the number of patients it will take to run clinical trials. So it's really complicated to do only time to clinical worsening as primary endpoint studies, although this is something we might wish. So the twist has been taken over the past years to use this trick of having secondary hierarchical endpoints. So for example, you have one study looking at 6-minute walking distance as a primary endpoint after, for example, 24 weeks. And then you have a further investigations. Patients are kept in the trial to look at time to clinical worsening as a first secondary endpoint, which then allows you to add some robustness on the sustainable benefit of a potential new therapy. The field is super crowded for now, and Jason mentioned that in his presentation as well. I think we need to be pragmatic also and make those trial running to bring treatments to our patients as early as possible. Now, patients-related outcome is something that is viewed as very important for the agencies, at least for the European agency. The European agencies are really working on including those PROs in the assessment of the benefit of a compound in the clinical trial. There's a little bit of a schizophrenia there because as much as the authorities want to have that, US patients want to have that, we as investigators want to have that, it's very unlikely that the drug for PH will be ever approved based on a PRO. But still, this is a way to go beyond, you know, the face-to-face consultation where you sit down in front of your PH doctor. And so the question comes, how do you feel? It's interesting, but it's way too simple. So we need to get more about those PROs, whether it's in trial and perhaps also as a way to apply an assessment of symptoms in the clinical setting.
The setup of the PH Center you presented looked very good from a patient perspective. Is this futuristic, or is it your impression that this is how the majority of PH centers currently look like?
Oh, it's a tricky one. It's not futuristic, it's existing. And many centers, and surely the centers of the panelists here, are working that way. Multidisciplinary, multi-professional, early and fast access. Several colleagues who weighed the same in the discussion. I can tell you that at our last MDT meeting on Wednesday, our social worker came up with something that we were not aware of in making our treatment decision. So everybody in a group has a say. Now, of course, it comes with three very important prerequisites. The first one is institutional. So how much an institution is willing to give to the PH center to organize care the best way possible. The second layer would be national. Is there a structure nationally that embeds PH centers within some kind of structure, such as what's happening in England, in the United Kingdom, or in France, where you have dedicated centers? And of course, the third aspect is the voice of the patients. And having worked with the patient association, at least in Belgium, for quite a long time, there was a shift between a will to have a PH specialist around the corner of every small town to the value of this pyramidal organization with referring physicians being included in the management and the treatment decision process. So futuristic, it's not. It's clearly an aspirational goal in some regions of the world, and I guess that this is something we would like, at least I'm sure the panelists would share my view, that this is something we should thrive for in countries where perhaps it's a little bit more complicated to organize care around PH.
The new randomized control trials and upcoming drugs sound exciting. Some pharmaceutical companies talk about possible reversal of the disease, not just slowing its progression. Is there any reality to this, or is it just a hype?
It's a little bit of both. We all hope to reverse and make the disease disappear. This is not just what's happening, even with the new therapies. Now, that said, if you ask me whether those new compounds and also the let's say the more standard compounds can reverse the course of the disease, I will tell you that reversing the course of the disease would be improving walking distance, decreasing PVR, delaying clinical worsening, decreasing NT-proBNP, improving symptoms. We are there already with a lot of the treatments we have. I wouldn't say it's a hype. I think that there is a little bit of rationale, but we cannot prove that we really reverse the disease. And I can put forward to you that a calcium channel blocker in a responder to nitric oxide testing is a disease-modifying drug. And this is the case that my friend Olivier Sidbon took at the CVCT forum in Washington last year. So I think we need to be very cautious about what may seem as a commercial message, and surely towards you patient. I'm going to give you one example. I'm a patient. I'm sitting in the waiting room having my good old oral combination therapy and feeling well, and I'm sitting by this nice gentleman who has this wonderful disease-modifying drug. But we feel the same. How am I going to react to the fact that he's receiving something that I don't have? So I think that as physicians, we owe you a little bit of explanation that goes beyond this simple say that it's reversing the disease.
So your point on how the guidelines favor initial triple combination therapies, do you think why do you think two major European registries show that only 15% of patients are on triple combination therapy at the time of their death? And we talk a lot about new therapies, but doesn't this indicate that there is a lot of unused potential in current treatment as well?
I think this is a very important point. It is a disappointment to see that it's not only following the guidelines, it's also following what is the evidence to support patient. I think we can do much better than what we do with what we have. One of the things we learned over the past couple of years is that the more aggressive in a good way you are over the first year of diagnosis or the first 2 years of diagnosis, the better might be your outcome. So the earlier you get your patient on double and then on triple, if stalling in an intermediate, let's say in a non-low risk category, probably the better. It is also striking in contrast with that to see the duration of disease in the most recent clinical trials that were published, showing that most patients have 8 years of survival or 9 years of survival from diagnosis, even on double or triple therapy, it indicates that we've probably have that subpopulation of patients who truly have PH and who have benefited from all the armamentarium we had so far. So I think that the message, surely not for the members of the panel here, but for our colleagues who maybe do not do PH as a main focus, do not have PH as a main focus, would be hit hard, hit early, and again, refer to the centers who have the knowledge. It's never, you're always helping a patient. If you don't master, for example, the intravenous therapy with prostanoids, send the patient to a center who knows, and that's for the benefit of patients. So this is I guess one of our mantras. It's going to depend on the setting, but surely let's do better with what we have.
But 85% of patients only being on single or double therapy when they die. Why do you think that is? Do you think it is because the patients themselves did not want IV medication? Do you think it's the doctors that don't prescribe it? Or do you think it's the authorities that don't allow it?
So it really depends. The two European registries that you mentioned are from countries where these are lands of milk and honey. All the treatment options are available. So the health authorities do not play a role in blocking a patient to receive a treatment. How many patients deny IV therapy? I mean, in our small center, it's very, very unusual. It also depends how confident you are to share your knowledge about this disease. So if I have no experience with something, I would probably be a little bit reluctant to initiate a treatment, but I would be very much encouraged to tell my patient, well, I'm going to send you to a center who knows what to do with this treatment. Again, this is the message we should give. And we've seen over the years that with such strategy, bonding and creating networks, regional or national networks, we get more of our colleagues be willing to send patient out to receive the best treatment. So I think it's more what we call in heart failure treatment inertia, which is in fact not really a good thing, because it's not matching the clinical evidence.
You talk about shared decision making. Both healthcare providers and patients must agree for this to happen. What is required from the patient side to be actively involved in shared decision making, in your view?
So for me, the first thing is knowledge. So what I can tell you very pragmatically what we do when I see a first patient being referred to us for assessment, I'm unfolding the diagnostic algorithm, and I'm explaining why the right heart cath is important, as Athena's pointed out, for the diagnostic, but also already for therapeutic orientation purposes. Once the diagnosis is made, we spend about 1 hour, 45 minutes, 1 hour. This is why my institution hates me, because it's taking a lot of time. But we are explaining the treatment algorithm and what are the options. We do leave room for the patient to express what she or he feels, but the bottom line is that we come with a proposal, and we're saying, this is what we're going to do with you. And then we enter in a dialogue. So knowledge is power. The more knowledge you give to the patient, the more the patient is going to be involved in care. And by the way, at this second consultation, when diagnosis is disclosed and the treatment algorithm is discussed, we also talk about clinical trials. And we also say that at some point, the patient may be asked to participate in a trial with a new medicines, which in fact happened to your fellow patients who were receiving the one we're prescribing to you now. So I think the most I would say is, I mean, the most important two things are knowledge and dialogue.
And I guess also this is an area where patient associations can play a role by helping empowering the patients with more knowledge.
Yep, absolutely.
Yeah, and when I think about myself, when I first was diagnosed, I did not know too much about PH, and I was kind of in shock. but then as the year goes by, then you start to learn more, and then maybe it's easier for you also to do shared decision making as the years go by.
Oh, sure. This has been a great change. You know, my gray hair tells how old I am and how long I've been in this field, and it has completely changed from a very close to be paternalistic point of view and dialogue with the patient to something that is more about empowerment. And I'm sure, Hal, we can give you our slides and you can present on our behalf without any problem, because your level of knowledge is very high. So thank you also for bringing the patient association that are extremely important in sharing, disseminating knowledge. And it's not a matter of your level of education. You know that, right? So you should speak to the patient the same way, whether they have a high degree or they're just they are workers. So everybody should be put at the same level.
Last question. You showed a reverse pyramid and how it's completely different for doctors and patients. In your opinion, is it possible to build a pyramid that both patients and doctors can agree on?
Yeah, so that will be a rectangle and not a pyramid, because I think and that would be a nice exercise to make, to have a discussion with patients saying, what are the 3 most important items you believe should be in, whether it's the clinical assessment or in the development of clinical trials. And I'm sure we will find some common grounds. Clearly, symptoms, PROs perhaps at least have an answer to that question.
Well, thank you so much for all your excellent answers. Okay, so we'll move on to the next presentation. I see we have 14 minutes left, so we are pretty much in schedule. So the last presentation was about new treatments for PH, clinical trials, and drugs in development. So first question, how long does it typically take to move through the 3 trial phases before a potential medication is approved? And is there any way to speed up the process if a drug seems especially promising?
Yeah, thank you for this question. Very good question. And to answer the first part of the question, it's highly variable between medications. It can take many years, though. And even once a drug has made it through a phase 3 trial, then the manufacturer has to apply to the regulatory agencies, usually in the United States first, but often simultaneously in Europe. And that approval process can even take 6 to 12 months. There are some ways to speed up the process for rare diseases, or what we call orphan diseases. And these are diseases that have that are rarer than 5 in 10,000 people, and that are life-threatening or debilitating. So PAH would meet those criteria. The third criteria that they have to establish to meet an orphan drug authorization is that there is no treatment available for the condition, or the treatment of interest has a major benefit. And so new, very innovative and effective pulmonary hypertension drugs could meet the orphan drug criteria, which can accelerate the process, and also it brings some other advantages to the manufacturer if they go through that process through the European regulatory body or in the United States. So there are ways to speed it up for rare diseases, but it still takes a considerable amount of time and investment. And ultimately, it depends on how big the trial is. So trials that require a few hundred patients may finish quicker than a trial that requires over 1,000 patients. And so this comes down a lot to clinical trial design. What are the endpoints in the trial, and how many patients it takes to show whether there's a benefit or not. Certainly, we've seen some drugs move through this process quicker, and other drugs have moved very slowly. So it does vary between therapies.
Then we have a question about sotatercept. Could people on blood thinning medication use sotatercept given the bleeding incidents detected during the trial?
Yeah, that's a very good question. So people on blood thinners were allowed in the sotatercept trials, and as you may know, it's now approved in the United States. And on the monograph, it does note that bleeding incidents, major bleeding incidents, are higher in patients who are treated with sotatercept who are on blood thinners, but also in patients who are on prostacyclins, which can increase the risk of bleeding. So So people on blood thinners can take sotatercept once it's available. I think, like with any drug, a decision needs to be made between the patient and the provider about what sort of risks they're willing to take. And this actually leads to a really important point about the use of blood thinners in PAH. There is decreasing enthusiasm for using blood thinners specifically for PAH. Now, they may be warranted for other conditions that a patient has, such as atrial fibrillation. So I think patients who are going to be treated with this medication need to talk to their physicians about whether they actually need to be on a blood thinner or not, because one way to mitigate some of that risk of bleeding would be to see if you could stop a blood thinner if there isn't a really strong reason to be on it.
People on intravenous medication hope to be able to switch to sotatercept. Are there any experiences or data supporting this transition?
Yeah, this is also a very good question. To clarify, people in the trial, the STELLAR trial, which led to the approval of sotatercept in the United States, many of them were on IV therapies at background. So sotatercept was added on top of their oral drugs and their IV drugs. So it's not a question of switching the IV drug to sotatercept, but a very interesting question that is coming up and patients are asking about is, if I'm doing super well on sotatercept, can I get rid of the pump? And that we don't know. We don't know if that's safe. It has happened. We know that it's been reported in the long-term extension study that I think the last data that was presented showed that of the over 400 patients who were treated with sotatercept, 13 of them had their prostacyclin completely removed. So small number, but we don't really know anything about the circumstances around that. And we don't know whether it's been successful or effective yet. So that question remains unanswered. So I think the key questions are, can that be done safely? We don't know that yet. There needs to be data on that before we start recommending it to patients.
Then I have a question about new drugs based on imatinib. Both AV101 and seralutinib seem to be based on imatinib. Are there any differences between these two drugs, and if any?
Right. So AV101 is an inhaled version of imatinib, and seralutinib is a different molecule, but they're both in the same class of medications called tyrosine kinase inhibitors, and they inhibit different molecules that are involved in the development of PAH, and there is quite a bit of overlap in what they target. Seralutinib, at least in animal studies, is reported to be more potent and less absorption when it's swallowed, so less potential risk of being absorbed into the bloodstream and causing some of the side effects or adverse events that we know oral imatinib can cause. Now, whether these two inhaled versions are going to be effective, we don't know that yet. They're both still in trials, and they almost certainly will never be compared head to head. So, they are very similar, and I think the differences in the clinical world will really depend on how effective they are, if they're effective, and what are the different adverse event profiles that we see in the clinical trials if they end up being successful. But to specifically answer the question, the main difference seems to be the potency of how seralutinib works compared to oral imatinib, and then also the amount that's absorbed in the bloodstream if it's swallowed, which we call oral bioavailability, seems to be low for seralutinib, which may theoretically make it a bit safer or less side effects.
The results of the pulmonary artery denervation study seems impressive. Is there any downside to denervation? Can it be used in conjunction with standard PH medication? And I've heard that one cannot receive a lung transplant if they have undergone denervation. Is that true?
Yeah, fantastic question. So denervation is still a bit early on. In PAH, it's only really been done in one big trial, which was performed in China. But the important thing about that trial is that although the results seem impressive, the patients weren't on the background PAH therapies. And so we still don't know whether this intervention is going to be effective on top of best medical treatment. So that question needs to be answered still. What is really interesting about denervation is that it also may have some benefits in other types of pulmonary hypertension, such as due to left heart disease. That's been looked at as well. So I think the jury is out. It hasn't really been proven to be effective, but it does seem to be promising and fairly safe. In the big pulmonary arterial hypertension trials, there were no major complications, and I think similar experience was seen in left heart disease. So in terms of long-term effectiveness and long-term complications, we don't really have the data on that yet. Can patients undergo a lung transplant? It's a good question. I was not able to find anything about this in the literature. When you look at where they do the denervation, it's pretty close to the heart in the big arteries of the lungs. And when we do a lung transplantation, the connection between the arteries from the donor lung and the recipient lung are a bit further out. So, and in fact, lung transplantation itself is a denervating procedure. When you take a lung out of somebody, you cut all of the nerves that go in. The main theoretical concern would be, is there some scar tissue that forms where the denervation was performed, and will that interfere with the connection of the arteries? So I think that that's something that we'll have to consider going forward, and it'll likely end up being a discussion with transplant surgeons at the time. But if the connections can be done a bit further out from where the denervation was performed, theoretically, it should still be possible, unless there's been some kind of a complication of the denervation where there's a narrowing of the artery, or we can see that there's clot or scar tissue that's formed on the imaging. But it's an excellent question that I think we have not answered yet.
I see we have 4 minutes left and 4 questions, so I guess we have 1 minute
I'll speed it up.
per question. We have seen a PH-ILD drug approved by the FDA in the US, but not by EMA in Europe. Any comments on this discrepancy?
Yeah, I think simply the discrepancy has to do with submission. So it's not that the drug wasn't approved in the EMA, it just hasn't even been, the company, I don't think, has even applied to it. But part of the complication with getting the inhaled treprostinil approved is also approval of the device that administers it, and getting what's called the CE approval of a device that administers either a nebulizer or an inhaler. The drug and the device both have to be approved, and my understanding is that process of device approval is currently a bit delayed or complicated in Europe. So that may be part of the reason, but it's not to say that it won't be available in the future. The company would just need to initiate that process if they haven't already, and get through the whole approval process of the drug and the device.
Okay. Regarding left heart disease, does it not make more sense to treat the underlying disease rather than the PH?
Well, absolutely. I mean, that's the first line, is to optimize the underlying disease, and Professor Vacheri will tell you that over and over again, that is the first step in treating PH due to left heart disease. It is a huge gap, though. I mean, some people, you can, especially in what we call HFpEF, or heart failure with preserved ejection fraction, there are very few approved and successful treatments for that condition, and a lot of patients still have disability, they have symptoms, and some of those may be due to pulmonary hypertension. So it's a great need, and I think many of us see as much of that group of patients as we do of PAH, because it's very common. So there's a huge burden of illness out there that needs to be identified. So I think we do need new treatments for PH due to left heart disease, but they won't likely be the same treatments that we have for PAH. And we need to make sure that patients are at least optimized before that.
In which countries in Europe is sotatercept available? What are the criteria for receiving this medication for a PAH patient?
Yeah, excellent question. To my knowledge, it's not available anywhere in terms of the approved process, but there are emerging options for compassionate use access in countries in Europe now that it is approved in the United States. But that I do know that the drug is under review, and that approval is or a decision about it is expected before the fall. So we don't know what will happen, but hopefully it will also be approved in Europe and available within the next 6 to 12 months.
Right. And then last question is from Nancy from Argentina. Today's clinical trials all seem to exclude patients on blood thinning medication. Are future trials likely to also have this exclusion criteria? Is it a risk now for PH patients to be on blood thinning medication?
Yeah, it's a lovely question and very similar to the previous one. I think it all comes down to what is the reason for being on the blood thinner medication. Is it because of a blood clot? Is it because of atrial fibrillation with a high risk of stroke? Or are they on it because of their PAH? And as I mentioned before, there's really not great evidence to support the use of blood thinners specifically for PAH if people haven't had a blood clot. So, the question would be, does the patient need a blood thinner or not? And many of the trials don't explicitly exclude patients on a blood thinner. So for instance, in the STELLAR trial of sotatercept, they were not excluded. The phase 3 trial of seralutinib, which is just starting, does have, it doesn't exclude everyone on a blood thinner, but people who are on a blood thinner that have certain other high-risk features. For instance, they've had a previous stroke or something else that would make them at high risk of bleeding. That is being considered in trial eligibility now. But it also depends on the mechanism of action of the drug. So I think people with these biologic agents or these tyrosine kinase inhibitors like imatinib and seralutinib were very concerned about the risk of bleeding. And the companies that are developing these drugs want to maximize the likelihood of success. So they want to make sure that they're going to show that the drug works in a safe manner in a group of patients. So I hope that answers the question. It doesn't seem to be an absolute exclusion in most trials.
Okay, thank you so much, and thank you to all four panelists. And we kept the time 1 minute over, I see. Thank you to you, and also thank you to all the audience out there. And all the audience, they will get a questionnaire to fill out. And what we are particularly interested in is if you like this type of setup where you can watch the presentation when a good time for you, and then have a Q&A session later. So thank you so much to all of you, and have a great weekend. Bye-bye.
Bye.
Bye-bye.
Bye bye, everyone.